till 3 5. So we'll start the class.
Yes, sir.
So we'll be talking one of the not so common diseases in the neurology, but it may be asked in short answer question as well. So motor neuron disease, as the name suggests, motor neuron disease. So these are the group of disease which include progressive degeneration and loss of motor neurons and replacement of this neuron with gliosis. It is the most common form and devastating progressive motor neuron degeneration. We have two common variants, that is Stargardt disease or low grade disease, also known as ALS, amyotrophic lateral sclerosis. So we have it may be of two form. That is a lower motor neuron type and upper motor neuron type. That is the hallmark of amyotrophic lateral sclerosis. In lower motor type, we have progressive muscular atrophy, that is PMA, also known as bulbar. And the upper motor type, we have primary lateral sclerosis, that is also known as pseudobulbar palsy. So meaning of amyotrophic lateral sclerosis is amyotrophic is without muscle nourishment. That is resulting of loss of nerve signal to the muscles. Lateral is there is localization of the damage of spinal cord, that is cortex spinal tract. That's why we have upper motor neuron sign as well. And sclerosis is hardening of nature of spinal cord. So in this case, we have both feature of upper motor neuron type signs and symptom and lower motor neuron type of signs and symptom. So there is diagnostic triad of ALS, that is upper motor neuron and lower motor neuron, and the progressive is very rapid. So if somebody asks you on Viva what is motor neuron disease, you may say amyotrophic lateral sclerosis is the most common variant, and there is feature of both upper motor and lower motor neuron type of signs and symptom. The incidence is one per 1 lakh population. Prevalence is 3 to 5 per 1 lakh, and we have males slightly predominance than the female one, and the peak onset is on 6 decade. So there is no racial predilection, and 90 to 95% sporadic. However, there are cases of familial or amyotrophic lateral sclerosis of 5 to 10%, and the median survival is from 3 to 5 years. So once you are diagnosed with ALS, so there is high chance of mortality within a few years. So as you can see in this figure, we have upper motor type as well, and there is a crossing of cortical spinal tract, and also involvement of lower part of the spinal cord and onto the nerve fibers of the muscle. So we have both the features of amyotrophic lateral sclerosis in the patient. So the upper motor neuron symptoms are the slowed movement. So we have paucity of movement. There is loss of muscle strength, as in the case of cortex spinal tract lesion, and stiffening and cramping. Stiffness is hallmark of upper motor neuron signs. There is emotional liability as well. There is a part of pseudobulbar palsy. So patient may start crying suddenly. So the high emotional symptom may be seen. And the first evidence of disease is insidious development of asymmetrical weakness, usually first evidence distally in one of the limbs. So we have distal weakness of either hand or the foot. So that is the initial part of the disease. So in the hand, the extensor over flexor weakness is more common. So there is cervical. There is in case of cervical, we have hyperactive deep tendon reflex spasticity. In case of lumbosacral, we have pathological deep tendon reflex, that extensor plantar signs and spasticity. In case of bulbar, we have jaw jerk, pseudobulbar palsy, granular tap, and dysarthria. In case of thoracic, we have loss of abdominal reflex. So at the various levels of spinal cord, there may be different clinical feature as well. So let's go to the lower motor neuron symptoms. These are loss of muscle strength and atrophy. Atrophy and fasciculars are the hallmark of lower motor neuron symptom in case of ALS. So when you just look at the fasciculation in the muscle, so you must think of ALS. Atrophy. So the person may have atrophy of this hand. There may be thinner and hyperthinner atrophy. The person is complaining of weakness, as well as there is atrophy of this muscle. Again, these are the finding suggestive of ALS. Patient also complain of muscle cramps as well. So we have lower motor symptoms. So what you need to remember is there is very less involvement of sensory, bowel, and bladder, as well as cognitive function. So person is able to pass normally bowel and bladder, and there is no involvement of sensory, as well as person is a bit alert. So there is no any cognitive function impairment in this cases. So what you have is only the upper motor neuron and lower motor neuron features combined in case of ALS. So diagnosis clinical picture, the signs and symptoms at the initial presentation is weakness. We have bulbar signs. We have atrophy. There is pain and cramps as well as fasciculation, paresthesia, weight loss, spasticity. Sorry. Just win it. Just win it, please. So we have spasticity, hypertony, and there are other conditions where the data is not equal. So most common feature is the weakness, and there is atrophy. So location of the weakness is paraparesis. We have weakness of bilateral lower limb, and there is generalized weakness in most of the cases. Next common is paraparesis, and patient also complain of weakness of one leg or one arm, or sometimes both arm as well. So what you need to remember is there is a case of weakness in case of even stroke as well. But in case of stroke, there is feature suggestive of upper motor neuron lesion, whereas in case of ALS, we have both feature of upper motor neuron lesion as well as patient may have atrophy, early atrophy as well. In case of stroke, they will have lateral. There is lateral atrophy, unused disused atrophy. But in case of ALS, we have both upper motor neuron sign and as well as atrophy as well together. So diagnostic line of ALS is definitive ALS is when three or more or the following are involved. That is vulvar, cervical, thoracic, and lumbosacral motor neurons. Is probable is when two sides are involved, and possible is when only one side is implicated. So remember those vulvar, cervical, thoracic, and lumbosacral motor neuron signs showed earlier. So we have cervical, we have lumbosacral, we have vulvar. If everything is present, that is highly chance of ALS. If two are present, that is possible, and if one isn't, that is not the feature of ALS. So if patient has these features like sensory symptoms, if the bladder and bowel involvement, if the autonomic nervous system dysfunction, if the patient has problem with vision, if there is movement disorder, if there is cognitive anomalies, so these are not the typical feature of ALS. So patient have likely the other diagnosis rather than ALS. Okay, so sorry. So what is the pathology? Pathology is hallmark of the motor neuron disease is the death of the lower motor neurons, and there is in the presental gyrus atrophy, and there is motor neuron undergoes shrinkage and often accumulated of the pigmented lipid. There is neural loss of the cranial nerve as well, and degeneration of the corticospinal tracts, and finally there is atrophy, shrinkage, and cell. Ultimately, there is gliosis. We have various terminals like bodies like Buena bodies, Iranos bodies, Lewis bodies, neuritic plaque, and neurofibrillary tangles. So there are sporadic pathogenesis is very multiple types. There may be some free radical toxicity. There is reduced mRNA or RNA content in the both those neurons. There may be some exotoxic neurotransmitters such as glutamate participate in the death of this motor neuron in ALS. So we have various mutations in case of even in case of familial type of ALS as well. So regarding the familial ALS, that is not so common. It is autosomal dominant, and we have equal incidence in both male and female. And unlike the sporadic ALS, there is impairment of the cognitive function as well against familial. And the incidence is unlike the sporadic, the incidence is younger in the case of familial type. The survival is quite more than the case of sporadic 15 years survival. So differential diagnosis may be there are other conditions which have similar features to ALS. These are toxicity like lead, mercury, or aluminum. Hypothyroidism, hyperparathyroidism, hypoglycemia also have some of the clinical features of ALS as well. There is enzyme deficiency like hexoaminidase A. We have certain malignancy where there is paraneoplastic symptoms in a case of lymphoma, small cell lung carcinoma. Also, cervical spondylosis also have some of the features of atrophy. There is some numbness. There is some spasticity as well. We have some paraproteinemia, and there is some multi-system diseases like Creutzfeldt-Jakob disease. We have ALS, Parkinson's disease, dementia. There is a common condition of spinocerebellar degeneration. Post-polio also have some of the features of both lower motor and upper motor type as well. There are some diseases like Lyme's disease, and beta-bitol deficiency also may have features of both upper and lower motor as well. But in case of vitamin B2 deficiency, there is some sensory symptom as well. So regarding the lab, we have CPK neck, creatine kinase level are typically normal, but may be increased to twice to three times in case of one normal in the case of half the patient. CSF measures mild protein elevation, but less than 100 mg per deciliter, and all the laboratory features are normal. So one of the important laboratory investigation is your knob conduction test or EMG. So in case of EMG, in case of knob conduction studies, we have normal sensory knob action potential in case of ALS, but there is low amplitude compound muscle action potential, which when the significant axon loss occurs. So we have sensory part is normal, but the motor part is abnormal in case of knob conduction studies. Median motor knob distal latencies may be also prolonged. In case of EMG, we have active denervation, fibrillation, and positive waves. There is fasciculation as well. There is large amplitude, prolonged duration, polyphasic motor unit action potential in case of ALS in the EMG. Also, we have motor unit action potential with rapid rate of more than 10 Hz. So in exam, you can just write what is the investigation of choice. You can go for knob conduction studies or EMG. So you can just write two sentences as well. EMG and knob conduction studies can be done for diagnosis of motor neuron disease. So we have normal sensory nerve action potential. We have compound motor action potential may be normal or slow decrease amplitude. We have fibrillation, fasciculation in case of EMG. So we have three hallmark. We have normal sensory nerve action potential. We have decreased compound motor action potential, and we have fibrillation and fasciculation in case of EMG. So we have various variant of ALS. So we'll just talk a few regarding this variant. This is just good to know. This is not the most new topic. We have progressive bulbar palsy, multivariant of ALS. Patient present with dysarthria, dysphagia, the excessive salivation, aspiration, and pseudobulbar signs. And the upper motor neuron dysfunction may result in spastic dysarthria with slow oral and tongue movement and strained voice. Dysphagia often initial more for liquid than the solids. There is hyperactive gag and jaw jerk reflex, and pseudobulbar affected with inappropriate laughing, crying, that is the emotional liability, crying and yawning. Lower motor neuron dysfunction lead to greater degree of weakness affecting face, palate, and tongue. So we have everything regarding the oral cavity and the face part. So we have dysarthria, dysphagia, we have excessive salivation, aspiration, then we have some emotional liability, and then there is some weakness of the face and palate and tongue muscles. There is primary lateral sclerosis, upper motor neuron syndrome. The rare disorder, weakness is typically distal and asymmetrical. Patient present with slowly progressive spastic paralysis and the bulbar palsy. Patient may also develop clinical lower motor neuron abnormality over the course of the disease. Frequently, patient may have subtle evidence of active and chronic determination of EMG or muscle biopsy at the diagnosis. So we have familial spastic paraplegia, that autosomal trait dominantly inherited. More than 20 family spastic paraplegia genes have now been identified. And symptoms begin in the third or the fourth decade. Progressive spastic weakness beginning in the distal lower extremities. There is long survival, presumably because of respiratory function is spared. So most of the cases of ALS usually die with respiratory failure because the involvement of muscle of the respiratory system as well. So ultimately, patient will be dependent, will have respiratory failure. Patient will have low PaO2 and high PCO2. So patient may be deprived of exhalation procedure, and patient will be using long-term BiPAP or CPAP machine, positive expiratory pressure machine, for their expiratory phase or to wash out the carbon dioxide. Okay. So we have other variant and lower motor neuron syndromes like multiple focal neuropathy, motor neuropathy. We have mononeuropathic multiplex. We have chronic CIDP. We have polyneuropathy, radiculopathy, we have plexopathy, we have Kennedy syndrome, hexamidase A deficiency, spinal muscle atrophy, SMA. We have post-polio syndrome, poliomyelitis, inclusion body myelitis. We have low motor neuron onset of ALS. We have progressive muscular atrophy. These are the low motor neuron syndromes. So in case of PMA, then one of the common of the low motor hallmark of ALS, we have low motor neuron syndrome. We have almost incidence of 8 to 10% of motor neuron disease of PMAs. Better prognosis than ALS of mean duration of 3 to 14 years. In case of ALS, we have only 2 to 5 years of survival. Bulbar involvement is rare. Bulbar is like the jaws of defeating dysarthria. Weakness is typically distal, like other cases, there is asymmetrical weakness. The majority of patients present in PMA eventually develops clinical UMN signs. A post-mortem examination of PMA patient typically shows pathologic evidence of UMN degeneration. Then we have candidate disease, that is spinal bulbar muscular atrophy. Age of onset is 3rd to 4th decade. We have excellent recessive. No other case of repeat correlation with the age of the onset. Then we have then these are the low motor neuron syndrome with limb girdle distribution of weakness. So we have pelvic muscle weakness in the case of cases. We have facial periorbital fasciculation. Fasciculation is again the hallmark of low motor type of motor neuron disease. There are tongue atrophy with longitudinal midline furrowing. So we have atrophy of the tongue. So the size of tongue is markedly reduced and there is some midline furrowing. Prominent muscle cramps. We have generalized fasciculation and atrophy. So hallmark of this low motor is primarily fasciculation and atrophy. If somebody asks what are the hallmarks feature of any form of lower motor neuron, that is atrophy and fasciculation. We have spinal bulbar muscular atrophy. The atrophies are decreased. Cognitive impairment may occur. There is hand tremor. The sensory examination may be normal. So we have a least involvement of sensory system. This is all the feature of the motor neuron disease. System manifestation may be gynecomastia, there is testicular atrophy, feminization, impotence, infertility, and diabetes. We have markedly abnormal sensory NCS, unlike the upper motor type. If we do a biopsy of pseudo nerve, there is significant loss of magnitude fibers. We have elevated CK, that may be more than 10 times. So we have abnormal sex hormones like androgen. A normal decrease estrogen may be elevated, FSH may be mildly elevated. Increase in the expansion of CAG repeats in the androgen gene receptor genes. We have next adult Tay-Sachs disease. These are adult onset predominantly alignment disease arising from B hexokinase deficiency, very slow progressive disease. Dysarthria and radiologically evidence cerebral atrophy may be prominent. Rarely spasticity may be present, though is generally absent. Okay, so regarding all these slides, so what I want you all to know is what is motor neuron disease. Or the most common form of motor neuron disease is ALS. We have Lagos disease. It may be of hallmark is the combination of upper motor neuron type of symptom or signs and lower motor neuron type of symptoms and signs, and it will be progressive. And upper motor type is usually have shown the cervical, maybe lumbar, sacral, and thoracic. If all these four are featured, that is diagnostic. And lower motor type may be fasciculation atrophy. How we diagnose? You can diagnose with simple EMG and now conduction test. So I want just you to remember this all few sentences of MND. So how to treat? You must do symptom management, nutritional management, respiratory management, palliative care, and therapy to slow disease progression. So we have symptomatic and supportive management is the part of the MND. So there is multidisciplinary approach to sensitive management, nutritional support, respiratory care, disease modifying therapy, pharmaceutical management of symptom, rehabilitation medicine, and palliative cares. So symptoms associated with motor neuron disease, these are dysarthria, dysphagia, excessive salivation, emotional liability, depression, weight loss, bladder urgency, sleep dysfunction, constipation, edema, pain, spasticity, cramps, weight loss, fatigue, and weakness. So we all have to treat symptomatically. So how do we treat excessive salivation? We can give some antisecretic agent like glycopyrrolate. We can also use amitriptyline that has anticholinergic action. We can also use some patches, scopolamine. And if the patient is on bedridden condition, we can also use suctioning machine at the home. So emotional liability can be treated with some antidepressant like SSRIs, amitriptyline. And you must also do some counseling and supportive measurement for this condition as well. Regarding spasticity, we can use baclofen. We can also do dantrolene sodium, that we call hyperpyrexia, that is side effect. We can also use tizanidine HCl. Diazepam can be used. Or we can also use some Botox injection for at the local site where there is increased tone of the muscle. And also can physical therapy and occupational therapy in condition as well. So how to weakness management, we can do roll-heighted walker, we can do wheelchair, we are Hoyer lift, cervical collar, we can do hospitalized bed, ramps, build up utensil, velcro fastener, raised toilet seats, soar chair, resting hand splint, grab bar. So these all will assist your weakness. Management dysphagia, significant weight loss, inadequate fluid and calorie intake. So we must consider in case of those conditions where there is significant weight loss, inadequate fluid or calorie intake, difficulty in swallowing medication, frequent choking during meals, we have prolonged meal time. If the FVC is less than 50%, there is still aspiration in the area. So if the person is having dysphagia, so this is the most common is the malnutrition. Malnutrition is so it is the person will having highly decreased intake due to some difficulty in swallowing. So regarding insufficiency, there is dyspnea and exhaustion. There is supine dyspnea. There is marked fatigue, excessive daytime somnolence, frequent nocturnal arousal, vivid dreams, morning headache. So we can consider initial support when there is symptom of nocturnal hyperventilation. There is hypoxia during nighttime with the FVC is less than 50% on the DLC or in the FE in the spirometry. With the evidence of significant oxygen desaturation may prolong time to death in long-term study. So treatment is these are the treatment that will basically halt the progression of the disease. The tamoxifen with riluzole. So drug of choice is riluzole. So riluzole is may come in MCQ as well. So what is the drug of choice for progression of MND? That is riluzole. We have thalidomide, TNF alpha. Stem cell is still on the study part. Stem cells transplantation in case of MND. So what is the prognosis? Prognosis is 50% death in 3 years, 20% live in 5 years, 10% live in 10 years. So worst prognosis is those who have bulbar onset of ALS, simultaneous arm and leg onset, if the patient is of older age, onset less than 40, 8.2 duration under assistance, that is 2.6 of duration. Okay, so this main part is this slide, riluzole. They may ask an exam. They may ask. Okay, they may ask you. So this one is very important. So how do you diagnose? Simple test, normal SNMP is a decreased compound motor action potential, and there is fibrillation and fasciculation in case of EMG. So this first slide is important. Okay, so diagnosis, this one is very important. So we have all features, 3 or 4, in case of definitive ALS, probable and possible. And this one. So what are the lower motor neuron fusion? They are loss of muscle strength, atrophy, fasciculation, and muscle cramp. And upper motor is cervical, lumbosacral, bulbar, and bulbar is very important because they have poor prognosis regarding the ALS. And this one is also important. And triad. So if somebody asks in a viva, there is triad of upper motor neuron, lower motor neuron, and it's highly progressive disease. And they may ask, what is the meaning of amyotrophic lateral sclerosis? Okay, so this one is the summarized one. So we have a lower motor type progressive muscular atrophy, upper motor type paramelted sclerosis. We have bulbar palsy, we have pseudobulbar palsy. Also known as Charcot's disease, a Lou Gehrig's disease. So ALS. So this one is important. Next slide is this one. This 4, 5, 6, 7, 8, N9. So this one is just remember a few slides. Just know what is MND. MND is basically the motor neuron disease. So it may have upper and lower motor neuron features. Diagnostic hallmark is both features, and diagnosis is done by EMG and knock-on studies. Or symptomatic and supportive. Riluzole may progress all the progression of disease. Okay, thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.